Hope your 15-minute break was refreshing as we get back into this discussion session titled Orthostatic Intolerance, Dysautonomia, and POTS will be discussed. After this session, you'll be able to better understand the etiology and pathogenesis of orthostatic intolerance, dysautonomia, and postural orthostatic tachycardia syndrome. You'll also be able to better understand the treatment and rehabilitation approaches to manage orthostatic intolerance, dysautonomia, and postural orthostatic tachycardia syndrome. Let's bring on our speakers to the screen now.
Hello, good afternoon. I think we are all here. Where's Emily? And we will be being joined by, there's Dr. Anjali as well. So, hello, my name's David Strain. I'm a clinical senior lecturer at the University of Exeter Medical School. I'm also been very heavily involved in the research into long COVID, having been COVID lead in my own hospital, having been part of the NHS long COVID task force representing the British Medical Association, and also being the clinical lead of one of the biggest trials looking at long COVID. And for this penultimate session, it is my absolute pleasure to be joined by Dr. Asad Khan from Doctors for ME and Long COVID's Kid Champion, and also their team POTS researcher. Lauren Stiles, who's the CEO from Dysautonomia International. She's a research assistant, a professor of neurology at the Stony Brook University Renaissance School of Medicine. Please forgive my 4-year-old in the background. My wife has just had to pop out. It always happens, doesn't it? Yes, Lauren Stiles, professor of neurology, Stony Brook University Renaissance School of Medicine in the States. Dr. Jenna Tosto Mancuso, who's the clinical director of Abilities Research Center at the Mount Sinai Health System from the New York. Emily Rich, who's an occupational therapist from Tucson Medical Center at the Texas Women's University. Lindsay Skipper from Long COVID Physio Peer Support, the co-director within the UK. And last but definitely not least, Dr. Anjali Agarwal, who is a long COVID physio advocacy co-director and a consultant physiotherapist in India. So we have a truly multinational faculty. And over the next 45 minutes, we're going to be talking about autonomic dysfunction. Just before we go in there, just want to take a quick moment to describe what that actually is. We have to remember the autonomic nervous system has all of those basic functions that basically we do without thinking. It controls everything from our heart rate, our body temperature, our breathing rate, digestion, whether we sweat. It connects the heart, the liver, your sweat glands and skin, right down to the interior muscles of the eye. You can only focus because of the autonomic nervous system. There are many different conditions that affect this. And when we start seeing autonomic dysfunction, it can affect pretty much any system in the body. It can speed up or slow down any bodily process. It can affect how we digest food. It can affect how we feel the sensation to pass urine. There can be anything that triggers it. But there are several key triggers when our autonomic nervous system ordinarily has to work overtime. Those include having a large meal. Those can include standing up or just getting up from sleep to wake. And what we are seeing is that there is a large number of post-viral conditions, and long COVID has really brought this to the forefront, that causes this autonomic dysfunction. Now, that's the medical description. That's all the stuff that we read in textbooks and we can hear about in textbooks. However, I think this is probably going to be far more relevant to hear what it's like to actually have autonomic dysfunction. And at this moment, I'm going to bring in Asad. Asad, I know you've been living with this for 2 years or so now, and I know you've been trialing many different treatments. Do you want to give us a quick overview of what it's like to actually have autonomic dysfunction?
Sure. Thank you very much for the opportunity here. What I'm going to say probably applies to lots of other people. I'm by no means unique, and there will be people who are a lot more severe than I am. But at my worst, I was completely intolerant of even lifting my head up the pillow. So it would trigger instant nausea and vomiting. It's worth remembering that autonomic dysfunction is not just a raised heart rate. As you said, any part of the body can be affected. So in my case, I had quite severe gastroparesis. So I couldn't tolerate any oral intake whatsoever. I also developed bladder issues, which meant that I was incontinent and I still had to wear pads. The nausea and insomnia were a delightful combination for a number of months. And I have to say that of all the different presentations I've had of my long COVID, so I have had urticaria and I have had MCAS, POTS was the one, along with other aspects of autonomic dysfunction, which brought me really close to taking my own life. It was torture. And this is borne out by some research where on a 10-point scale, patients who developed POTS reported a drop from 7.5 to 3.75 in their quality of life. And that's massive. And imagine living like that for years, sometimes decades. The stereotype is the young Caucasian female who repeatedly presents to hospital and is labeled anxious and sent home. And being told that. I mean, I had a few months of being like that, and I cannot imagine what it must be like to live like that for years and years. I'm better now, by the way, but still not fully healed, and I can talk about what helped in the discussion later on.
Thanks, Asad. And sorry, I'm seeing the comments in the chat. I'm keeping a very careful eye on the chat because we are deliberately going to be answering as many of your questions as possible. And just for information, the intruder is Chrissy. She is 4. She loves dressing up as a princess and thankfully has not been affected by COVID in any way, shape or form. I'm sure she will be back though. So Asad's just given us a quick description of what it felt like to actually experience some of these symptoms. Lindsay, you've also suffered with some of these symptoms. How do you go about planning your entire life when you're living with these symptoms?
Yes, like Asad, my most disabling part of long COVID has probably been my dysautonomia. So I have POTS and inappropriate sinus tachycardia. And when I think about how it's affected me, there isn't actually any part of my life that hasn't been affected by having dysautonomia. I can't just wake up in the morning and go to the toilet. I have to drink a lot of fluid, take my medication and wait and wait and wait. And then eventually I can rise from the bed and safely make it to the toilet. It's such a simple thing that we all took for granted before we had dysautonomia, but you can't just nip to the loo anymore because chances are you'll end up flat on your face. I have to spend my whole day planning how I do things. So having a shower is not just nipping in the shower. I have to get everything ready, have a rest, get the shower stall ready, get back, have a rest, dry myself sitting down. I can't clean my teeth just standing up. All those really simple things that you don't even think about, but actually you just can't do anymore without becoming really tachycardic or short of breath or feeling faint, as some people do. Eating, I mean, I love food and I've totally had to change what I eat and how I eat. I can't eat a normal sized meal anymore. And I've always been a slighter build person. And so I need to get calories in. It's just how I am. But I can't eat those large volumes of food because then I feel really unwell. And carbohydrate is just really difficult. So I have to gradually add little bits of carbohydrate in through the day so that I don't then have hypos. But I also don't become tachycardic from eating too much. The other thing that's really difficult is it's so unpredictable. You know, you sort of, like Asad, I'm better than I was, but I'm a long way from where I used to be. And even with all my medication, my endless drinking, all the salt supplements, I can think that I've got a hold on, okay, this is how my life works. And then it's the premenstrual week or ovulation week, or we have a 4-day heat wave. And suddenly everything has gone to pot. When we had the 4 days heat wave, which we had in the UK, which is pretty rare, I barely had any blood pressure. I just could not function. So even my very limited function just went. And you can't plan for that. And And so it's really hard to commit to anything. I can't work at all at the moment. My brain fog is a really big problem as well. But even if I didn't have the brain fog, physically, I just can't predict day to day or even hour to hour, because one bit of the day I can be really tachycardic and then suddenly I'm really bradycardic. So it's very hard to plan your life. And of course, people look at me and I'm sat on a chair, and it has taken me 2 days to prepare to sit on this chair for 45 minutes and talk to everybody. And I look fine. I look well. But if you could see the massive preparation that has gone in to be able to just sit on this chair for 45 minutes, people would realize that actually it's really life affecting.
And that gives us a bit of an insight in what it's like to have this condition. And of course, many of the day-to-day activities that used to take for granted, we all still do take for granted, running around after my 4-year-old, just become impossible when you have to plan your life around these sorts of symptoms. And yet there are still many of my peers, many of my colleagues in the healthcare profession that don't find it difficult to appreciate the importance of this, and find it difficult just to accept what's being said, and need some sort of concrete test in order to take that further. Now, Lauren, I know you've been doing a tremendous amount of work, both in the research field and also in an advocacy field, in getting these diagnostic tests right. Do you want to give a quick overview to people as to what sort of tests that we may be requesting for our patients, and also what our patients have to go through in order to have these tests? Lauren?
Yeah, sure. So I started out in this field as a undiagnosed bedridden POTS patient 12 years ago with an acute onset, not from COVID, of course, that long ago. Actually, mine was a concussive onset. So what Lindsay and Dr. Asad or Dr. Khan are saying are exactly sort of the horror of what I went through 12 years ago. And I don't want to candy coat things and say, oh, everyone magically gets better, but I am dramatically better 12 years later. I probably still meet the POTS criteria on tilt table testing, which is what I'm going to talk about. Sorry, but very, I would say high functioning POTS patient. So the testing, first, I want to emphasize that the autonomic problems we're seeing in long COVID are not just POTS. That's the diagnosis that kind of gets the most name recognition, but it's POTS, it's orthostatic intolerance without the tachycardia part. So it's sort of the same as POTS with not meeting the heart rate criteria. Some people have a more severe autonomic problem that can cause orthostatic hypotension. Some people have inappropriate sinus tachycardia, which is where just a very consistently high elevated heart rate, regardless of your body position. And these things can overlap a bit and can sort of evolve over the course of an illness, especially when you're in the new onset phase of it. Luckily, we would say sort of most people would have it sort of the worst at the beginning when it starts, and then it kind of plateaus. And then hopefully with supportive lifestyle changes and in most cases, pharmaceutical treatment is also needed to help someone get to this point of a more functional state where they're feeling better. So how are we diagnosing this? Well, in an ideal world, you could get formal autonomic function testing, but there are very few labs around the world that do this. In the US, we have less than 50 labs that do this for the whole, 330 million people who live here. In the UK, there's a handful of syncope clinics that do this. There's some other European countries, around the world, it's very hard to find a autonomic specialist. The second best bet is to find an electrophysiologist who has a tilt table test. And so they don't have the complete battery of autonomic testing. They just have a tilt table test there where they tilt you up to about 70 to 80 degrees upright, and they assess your heart rate and blood pressure over about a 10-minute period. And then if you can't access that, any doctor or even any person could do an orthostatic vitals test. This is 10 minutes. You lay down and measure your heart rate and blood pressure after laying down for about 5 minutes, relaxing. And then you would stand upright carefully. and stand still. Don't wiggle the arms and talk and stuff like that. Everything can change your heart rate very easily. And then we'd measure the heart rate and blood pressure at like 1, 3, 5, and 10 minutes. At a really good autonomic lab, they measure it continuously, but that's pretty hard to do at home. And you're looking for different heart rate and blood pressure changes that match diagnostic criteria. The sort of simplified way of breaking it down is if you have a lot of tachycardia when you stand up, it might be POTS. If you have a big drop in your blood pressure when you stand up, it might be orthostatic hypotension. And if you have a lot of symptoms of lightheadedness and dizziness when you stand, but your heart rate and blood pressure stays pretty normal, you might have orthostatic intolerance. Interestingly, the treatment is pretty much the same for all three of these. They're all sort of differing degrees of severity. So I don't know if you want me to go in depth more. We have actually, I think, some other tests we were going to talk about, right? So in addition to the tilt table testing, another important test you might want to ask for is small fiber neuropathy testing. So in the US, the autonomic neurology labs do this pretty routinely. In the UK, most of the autonomic clinics are the syncope clinics, and they don't really focus on the autonomic neuropathy piece as much, but some of them are have connections with neurologists who do this. And so when you autonomic small fibers are pretty hard to assess, but you can do a skin biopsy that looks at your sensory small fibers. And that is sort of a bellwether of what's going on with your autonomic nervous system. And we know prior to COVID, more than half of POTS patients have a small fiber neuropathy, and that's believed to contribute to the blood flow problem that they have because their autonomic small fibers are not working properly to vasoconstrict their blood vessels. So if you can get that testing, that's great, but it's pretty hard. And it's not always the definitive answer on whether you have a neuropathy type problem, because you could actually have a normal skin biopsy, but still have a different type of neuropathy that's not as easy to see with the current testing. So I'm not sure if that's entirely helpful because it's very hard to cover all of autonomic testing in about 5 minutes, but just to give an oversight of it.
So that's a really good oversight of the different processes and the different things that we actually put our patients through, whether they be the biopsies or the 10-minute scans. And we're seeing a lot of comments in the chat bar that many GPs, many family practitioners don't actually have 10 minutes to do this. So it's often not done well. And the tilt table as a process is not very pleasant. Now, I've been on the giving end of a tilt table. Well, can I just quickly come to Emily, because you've actually had a tilt table. So before we send people for this process, we really need to explain to them what it's going to be like. Emily, do you want to describe the process?
Yeah, it's definitely not pleasant for most people. Some people say it's the worst time that their symptoms have ever been, which is sort of the point of it, is to simulate what's happening to the nervous system. But basically, they strap you to a table and you're laying flat, and they tilt your head up. And so the whole table tilts at an angle. And they're measuring your heart rate as that's happening, and they're asking you about your symptoms. Usually they try and do it for at least 10 minutes to be sure they can capture those symptoms, sometimes more. But if you feel like you're definitely going to pass out, you tell the person and they will lower the table back down. You know, that's not ideal. They want to capture as much as they can. But and then full autonomic testing would also include sweat testing. So they're seeing how that's a part of your autonomic nervous system. If that is happening normally, for example, in your feet, as it is in different other parts of your body. And then also looking at the response of the Valsalva maneuver, or basically straining, trying to exhale against pressure. And they're seeing what your body does against that. So there's different components, but it's pretty miserable for most people. So usually recommend having someone to drive you home if you can. And just know that, you know, you're hopefully going to recover and you'll feel like you did before again, but it's intended to sort of simulate those symptoms.
Okay, so that's a really good guide. So anybody who is seeing somebody that you're planning on sending for a tilt table test, you need to let them know that they'll need someone to drive, and they'll probably need to prepare the day before and just blot out the day afterwards, because it will take a long time to recover from something like this. Now, I want to come back to something that Lauren said, because Lauren didn't get these symptoms as a result of COVID, like many others, or for that matter, for any other post-viral. She describes that it first came on as a result of a head injury. Anjali, can I come to you? Are there other conditions that we know about that are associated with autonomic dysfunction or POTS or these different phenomenons?
David, we see a lot in EDS, Ehlers-Danlos syndromes, in cases of connective tissue disorders and even Marfan syndromes. And these are all connective tissue disorders whereby the connective tissue is your blood vessel, which are supposed to be pumping the blood against gravity when one person stands up. And that's the time when we see a majority of these patients have dysautonomia or POTS, and a trifactor with MCAS also, which is too much of reactions to food, to stress environment, any kind of triggers around the house, or even for emotional health and emotional triggers. So a lot of connective tissue has a lot of role to play with COVID, I find. And many of my patients have got affected with COVID and now have been diagnosed with Ehlers-Danlos syndrome and Marfan syndrome. So the key thing to understand is many of these connective tissue disorders are there in many of the hypermobile kind of candidates. They're too bendy, or they can stretch beyond a point of their abilities. And we do a testing called Beighton scoring in normal kind of clinical settings in the physiotherapy setup. And we find that they're too flexible, and they'll always talk about that they were very good with ballet dancing, or they were very good with acrobatics or gymnastics as a child. And many of the clinicians will think it's cool to be doing a yogic asana, which is like you can do a split, you can do a kind of a child who was jumping around the trees. But all these things we have to evaluate, considering that Ehlers-Danlos syndrome or connective tissue disorders have a big role to play towards dysautonomia. And many of my patients of Ehlers-Danlos syndromes have dysautonomia by default. And after getting COVID, they kind of getting it more worse. And many of the patients who were never knowing that they were hypermobile, they just knew that they were bendy and that they were very flexible. They have something called a dysautonomia, which we kind of now find out that is Ehlers-Danlos syndrome, which the family. So it runs in genetically within the family. A mother or a father might have one portion of the gene which is getting carried over to the child, and that goes on in family. So we have seen that in a family of 4 to 5 people, we have everybody who's very hypermobile. There's one person who has got more affected with connective tissue. Of them would have POTS syndromes. So we do a genetic profiling of each, or we do just an analysis of the clinical.
I think we are losing Anjali. No, we've lost Anjali, but she's just given us a great overview there, saying that the POTS syndrome is associated with these other hypermobile conditions. It is associated for many other conditions. And actually, a lot of these have been diagnosed since people have come to light with long COVID. And similarly, there are many other associated symptoms. There are some people with certain immunoglobulin deficiencies. There's some people with mast activation syndrome, mast cell activation syndrome, that are similarly only being diagnosed, brought to light through their autonomic dysfunction. Now, the autonomic dysfunction, we've spoken about it, and it does feature very nicely in the long COVID spectrum. But what is our normal natural history? I mean, again, Lauren, you highlighted that yours over 12 years has slowly got better. Emily, do you want to tell us? Sorry, Jenna, would you like to tell us about the natural history and what we can expect when it comes to this?
Sure, absolutely. So I think as we talk about the natural history of autonomic dysfunction for individuals with long COVID, to highlight a point that Lauren had made earlier, right? When we think about the presentation, it's not a one size fits all. It's not POTS really gets the spotlight, but there are other clinical presentations to be thinking about. And when we think about autonomic dysfunction across the continuum of care, we really are thinking about that underlying pathophysiological mechanism. And so, as we alluded to early in the talk, the idea that oftentimes we are seeing autonomic dysfunction in the light of positional changes, as some might see, especially again, things like POTS. When we look at the role of the autonomic nervous system in mediating peripheral vasoconstriction and dilation, sympathetic and parasympathetic tone, responses to changes in vascular pressure, et cetera. What we largely find is that for individuals who are experiencing post-viral dysautonomia, oftentimes the symptoms are more significant and more serious very early on in the diagnosis or in the symptom onset. So really, as we think about long COVID, we look at that post 4 weeks from acute onset and thereby after. So in those early phases, the symptoms can be incredibly prevalent, which really just underscores the absolute necessity of early diagnosis and early detection. So as we're starting to, as a community, highlight those symptom presentations, and also from a medical standpoint, more and more folks hopefully will be able to pick up on those symptom presentations. We can ideally drive early diagnosis and intervention. That being said, we do find that over the course of the illness, like we've pointed out, many folks do see degrees of symptom stabilization, but that is something that can also be managed with interventions like symptom management strategies, pharmacological targets, et cetera.
Thank you. So we've got some of the natural history with and without therapy there. And part of that is obviously going to have access to the right person, what help is. But what does good quality help look like? I mean, clearly, I'm a secondary care physician, so I have my own view. But what does good quality help like to people with this condition? Emily, what's your sense of what good quality help should look like?
I think the number one most important thing that I look for is someone who's willing to listen. If someone comes in and a provider says they already know all there is to know, if they really are an expert, that's great. But I think this opportunity to learn and to collaborate with a patient is probably the most important thing. Patients, unfortunately, or fortunately with dysautonomias, often do their own research. They come in with articles and they say, I think I might have this. And so there are resources available for patients to help be able to save their provider time in that way. And so looking for a provider who's willing to partner with you. I also think it's really challenging to find the right people sometimes. It's exhausting going from provider to provider, being labeled as doctor shopping, and so looking into support groups online, especially things like Facebook support groups, and the different nonprofit organization like Lauren's Dysautonomia International, they do have a list online of providers, which is a great place to start. And I included that list in the Padlet, so you can find that there. And then for other providers like Allied Health, often it's a lot more challenging, but I actually included a list that I have of the providers, and we're continuing to add to that list. But, oftentimes it's actually people who have the condition. As I mentioned before, I have POTS, and I specialize in seeing these folks. But fortunately, more and more people are getting involved in treating these patients as well. So.
Thank you, Emily. So that's a great overview of where we're up to. And we're about halfway through. So at this point, I just want to have a quick look at some of the questions that we've been coming in. So far, we've heard what it's like to actually experience long COVID and the autonomic dysfunction that goes with it. And we've also had a fair number of comments in the chat from people that have experienced this prior to long COVID, but it's been exacerbated. We've also had a few comments about the vaccine. Now, the vaccine's a really interesting area that actually the majority of people who've got autonomic dysfunction from long COVID actually get better after their vaccine to some degree, but about a third will have no benefit and a very small proportion will get worse. For people who've had autonomic dysfunction prior to vaccine, actually vaccination demonstrated very different results depending on whether it was the adenoviral vector. So that would be the AstraZeneca vaccine in the UK, the Janssen vaccine in the States, the biotech in India, for example, they actually tended to make orthostatic intolerance slightly worse rather than better. But the mRNA vaccines did seem to make the vast majority of people better. I'll spend a moment on that because there's been a lot of comments on that on the chat bar. So when we're looking for our boosters, and clearly there is a sequential impact on this, people who've got long COVID, if they get COVID again, tend to get worse rather than better. So it's still important to be vaccinated there. We've got lots of questions on sleep, and I am going to come to our panel to find out what they mentioned for that, because sleep is so important. And then there's a bit of a discussion about the NASA lean test and whether that's effective. Actually, the NASA themselves have stopped using the NASA lean test. And there's one or two comments on there about whether you actually need a tilt test to diagnosis. And the reality is, if you can get good quality care, if you can try all sorts of home management strategies, you don't necessarily need to have these diagnostic tests, because actually having a diagnosis is far less important than getting the right treatments in order to make people feel better. And actually, on that note, Emily, I want to come back to you. What can people who are experiencing this, what can they actually try at home in order to combat these symptoms?
Yeah, there's actually lots and lots of strategies outside of pharmacologic interventions that we can use, with the number one thing being salt and fluid. So most people with different forms of autonomic dysfunction are told to increase their sodium and their fluid, with the reason being that actually increases your blood volume, so the amount of blood circulating through your body, and that often helps to make those positional changes not as challenging. The amount varies between providers and, depending on your state, but it's quite a bit of water, usually 100 plus ounces or 2 to 4 liters, and 8 to 12 grams of salt, which would be 3,000 to 4,500 milligrams of sodium. So looking at labels, learning how to, understand what your baseline level of sodium and water needs are each day, or fluid in general. Another basic one that we use is compression garments. So a lot of people do really well, especially with full length compression. So that goes on their lower body, from your ankles or foot all the way up to your waist. And then additionally, wearing an abdominal compression binder, that is going to you have a lot of benefit for most people. But if you're not able to tolerate that, then sometimes even wearing just the abdominal binder is really helpful. And worst case, just wearing socks or something, or just like leggings, but trying to get at least 20 to 30 milligrams of mercury of compression, higher if you can tolerate it. And then using things like elevating the head of your bed 4 to 6 inches. So not meaning just propping your head up, but actually changing the angle of your bed, or using a full body wedge. What that does is it helps you to retain more fluid overnight. And that can help some people who are waking up during the night needing to go to the bathroom regularly. That actually is something that can help sleep, but it also definitely helps with a lot of those positional changes, symptoms. Overall, regulating your autonomic nervous system using breathing strategies, vagus nerve stimulation, and different strategies to try and help that fight or flight response to decrease, and to help your body be more resilient and going into that rest and digest response. And that is the number one thing I would say for sleep, is really trying to get your body into that state before bed as much as possible, preventing those adrenaline surges to the degree that you can, and getting your body to this place that can rest as much as possible.
Thanks, Emily. And Asad, I just want to come back to you briefly, because you mentioned that you've tried a lot of these things and this sleep was a big problem for you. What have you managed to do? We've got lots of people asking how you've been able to fix your symptoms.
Okay, happy to talk about that. Firstly, I'd like just to make a comment on the vaccine. People respond differently. The virus gave me inappropriate sinus tachycardia, but my orthostatic intolerance and POTS came on within hours of the vaccine, which was the Pfizer in my case. So people can respond differently. So what was helpful for me? My table was negative because I didn't last very long on it, although I had multiple positive active stand tests at home. And the autonomic department wrote to me saying I had no evidence of autonomic dysfunction based on that tilt test that was inadequate. But obviously I had my head screwed on and I didn't accept that, and I pursued a second opinion. I think my message to anybody treating these conditions is that in the absence of a conclusive test, you can still make a clinical diagnosis of a dysautonomia or orthostatic intolerance. And even if your heart rate doesn't hit the 30 threshold on standing, you can still be really disabled. And findings fluctuate from day to day, and your active stand test or naphthalene test results will fluctuate as well. And as Lauren said, the treatment is similar, whether or not you hit the criteria. And certainly, while fluid compression and salt will help some people, they're not going to be enough for those who are more severely affected. We do have drugs available, and whilst tests are important, waiting for tests should not delay the institution of pharmacotherapy. As I said, tests can have false negative, and that includes skin biopsies. So I've been through all the drugs. What I found helpful was a long-acting beta blocker, an analog. It's a non-selective one, and it works in two ways. So it'll slow the heart rate down, but it also counteract the vasodilatation that occurs in your lower limb veins, so that there is less pooling in your legs. So that's been really helpful. I, at one point, was on beta blockers and ivabradine. Ivabradine is a bit of a tricky one because lots of primary care physicians aren't really willing to prescribe it, but it is a relatively safe drug, and it's been used in angina for a very long time. Midodrine can be really helpful for some people. I couldn't tolerate it at the beginning because I had hyperadrenergic POTS. But now that my blood pressure is better, I am on it, and it's definitely made a difference. Pyridostigmine can help with postural symptoms as well, as can fludrocortisone, which helps retain fluid. So it's a matter of trial and error, and everybody will be different. What works for one person will not work for another one. And then there are second-line drugs, such as methyl-dopa, clonidine, octreotide, and SSRIs, which are centrally acting. But then, apart from these, there are some other things that I found useful as well. In my case, anticoagulation helped the POTS. Now, this may sound weird, but I think in long COVID at least, ischemia of the small fibers due to microclotting will be contributing to the dysautonomia. But obviously, this should only be administered in expert hands. I'm talking about anticoagulation here. And I was lucky to have an expert looking after me, although I had to travel abroad for this. Other things that have helped me: vagus nerve stimulation using a TENS machine, breath work, particularly coherence breathing, cranial osteopathy, anything that would activate the vagus definitely improved my symptoms, and also objectively my HRV. Going into a cryosauna and cold baths and showers have been very effective as well. Attention to gut health. There have been some case reports of people who had MCAS or SIBO, and when that was treated, then the dysautonomia got better as well. So for me, a good Epsom salt clear out and balancing of the microbiome based on my microbiome results have been really helpful, and it's really reduced my medication burden. I would say that MCAS is probably present in the majority of patients with dysautonomia, particularly if it's post-viral. So it's important to get that under control as well, even if the MCAS symptoms aren't that florid. A trial of H1 and H2 blockade wouldn't harm you. And there's some evidence that the vagus nerve is directly infiltrated by the virus. So famotidine actually counteracts that. It acts directly on the vagus nerve. So that's quite a useful drug. Sleep-wise, stopping eating before 6, eliminating gluten has really helped me. Eliminating simple carbohydrates. Melatonin, sometimes you need to take megadoses because we're deficient in gut melatonin because we have ischemic guts. So I was at one stage on 50 milligrams, which, I wouldn't advise trying without supervision, but anything less than 10 is unlikely to help. Other things that can be helpful to increase your slow wave sleep. You can take 5-hydroxytryptophan So 5-hydroxytryptophan is an amino acid, and that can really increase the amount of slow wave sleep, and you can feel more rested in the morning. There are other drugs that you can try, such as trazodone and mianserin. They also improve the amount of that deep slow wave sleep. So in a nutshell, I've tried to get through as much as possible that's helping. As you can tell, I've been through most treatments, and there are more, but I'll try and put most of this in the chat.
Thank you, Asad. So that's pretty much a great overview of everything from the alpha right through to the droxidopa right at the end. And this will all be in the chat, which you'll be able to copy and paste to afterwards. I think after this, we might actually get a good summary of what we've been trialed, so we can get some sorts of priorities. Now, just in our very last 5 minutes, I want to come to Lindsay, because this is lots of really useful information and lots of stuff that people will try at home, often before they get to see their GP or their family practitioner. Lindsay, what is the most important information from your experience to take with you when you go and see your GP, remembering that you're only likely to have 5 or 10 minutes of conversation with them? What do they really need to know?
I think planning before you go what you want to say to them is really important, and collect some hard data. So you may choose to buy a device that will record your heart rate. Some of them are not terribly valid, so think about which one you get. And we've put some links on the Padlet for good resources to look for that. But get some data from when you're lying to when you're sitting to when you're standing. Don't just take one set of data. It needs to be repetitive. Every time I do this, this is what's happening, or most times, this is what's happening. You can get blood pressure monitors pretty cheaply. And again, there are lots of validated, fairly cheap ones out there. So again, you can look at your blood pressure when lying, sitting and standing. And again, do it repeatedly so that you've got that good spread of information, and you're not just saying, oh, once my blood pressure was this, because the GP or the primary care physician just won't take that. Think about other symptoms as well. It's not just about dizziness on standing. How is your gut? Are you having excessive sweating? Is your sleep affected? Are you paralyzed by migraines? Do your feet turn a funny color purple? See, my words have gone. Do your feet turn a funny purple color? If you could see my feet now, you would be horrified. They're practically black, and that's in my massive compression stockings. But this peripheral acrocyanosis happens in about 50% of people with POTS, where the blood is just pooling peripherally in your feet or if your hands are down. Do you find certain times of the month worse? If you have a menstrual cycle, are you affected by hot weather? Get that good collection of data to take with you. And I think informing yourself, so looking at Dysautonomia International, looking at POTS UK websites. I have to say I diagnosed myself after watching some of the York cardiology videos, which again, that's on the Padlet, because I watched Dr. Gupta describe someone with POTS and thought, that's me. Oh my goodness. It was word for word. And if you have to take that information to the GP or the primary care physician, then do, but have that data, a good set of data, not a one-off, but over several days of what makes you worse, what makes you better. Am I fine when I'm lying down? I mean, that's not a myocarditis, for example, or another heart problem. If you're okay lying down, but you're not okay standing up, that's telling you something. Although I do appreciate some people lying down. If you've got inappropriate sinus tachycardia, you can be tachycardic the whole time. But have a good set of comprehensive data written down so that when your brain goes, when you're confronted by that person, you can just read it out.
Thank you. And that gives us a really good description of the condition, of what we can expect for it, and what we can actually do to help ourselves. But this 45 minutes has just flown by, and we really want to thank our experts, because these are experts who, as we can even see, have really put themselves out to talk about their lives. So I want to take a moment to thank Dr. Asad Khan, Lauren Stiles, Dr. Jenny Tosto Mancuso, Emily Rich, Lindsay Skipper, and Dr. Anjali Agarwal. This has been a fabulous session, hearing about what it's like to experience autonomic dysfunction, about how best to diagnose it, and then some of the treatments that we can put on there. Have a look at the chat bar. There's many of those drugs that Dr. Khan's spoken about are in there. I will be adding some more to that based on our own experience. And on that note, I really want to thank you for your attention and hope you enjoy your 15 minutes break before you come back for that final session. Thank you very much, everyone.
Thank you.